to do that has been mentioned. There's a pilot study going to be launched next year at Waitemata looking at essentially the presence of blood within the bowel content, and that will hopefully be adopted then as a nationwide screening test. I think that's all I was formally going to say. I'm happy to take any questions at all that you have about men's health or other issues.
Any questions?
Yeah.
Arthur.
I thought there was a big argument going on at the moment about PSA. Is that part of the test when you say you get tested?
That's right. So the prostate screening is based really on two things: a blood test and an examination. A lot of people try and omit the examination, obvious reasons, patients and doctors actually, and really the most appropriate thing to do is to have the PSA and the examination done. So the screening test, the big screening studies that were done in the States and Europe have all looked at the PSA levels, and then if the PSA level is high, you do a prostate biopsy. The concern has been, so the concern with that has been that we diagnose prostate cancers that need not be treated, and the ones that we treat are associated with side effects. But in Scandinavia, I mean, Scandinavians pretty much with healthcare do what they're told, right? And they just front up and they do what they're told by the doctors. It's a bit different here. So in a study over there, they randomised patients with prostate cancer to have treatment or just be watched. And the mortality data, your death rate was a lot higher if you were watched as opposed to treated. So there is actually plenty of evidence, if you look at all these studies, that says that checking a PSA, subsequent biopsy and treatment will prolong your life. The most important thing if you're going to choose surgery is to choose a high volume surgeon and a high volume hospital. There are some of the surgeons in the UK are doing 2 or 3 prostate removals a year, whereas you really need to be doing it every week to get good at it.
Yes, good afternoon. I'm interested in the way that statistics are used in medicine. So we have a whole bunch of stuff here about people who get prostate cancer, but only 3% die, and so on and so forth. It becomes quite hard sometimes as a non-practitioner to understand what to believe. And the one that raised this question in my mind was the commentary on the waist measurement being 100 centimetres, or whatever the number is. I read in the paper the other day that that's just a load of bunkum. There was a study done in Spain which showed that that wasn't the case. There was no correlation between heart statistics and waist measurement. How do you know where to draw the line?
So there are several things. I mean, there's lots of things talking about looking at the quality of a study. So you can't translate a Spanish study into the New Zealand environment. That's fairly obvious. And the way we've looked at statins, for example, is to translate the lipid study that was done on atorvastatin in Australia and New Zealand. So you have to look at a like population, and clearly therefore you can't extrapolate the Spanish with their Spanish diet and habits and lifestyle to here. So you have to look at those sorts of things. You have to look at the sample size, and then you have to go through in detail how the study was conducted. The difficulty, of course, is it's very easy for someone just to get a blanket statement, to get it published, and to get it published in the media with no real critical review. So if you're going to look at something in a critical way, the study or the statement needs to be published in a peer-reviewed journal. So it needs to be in a proper medical journal, where the reading audience has the right to reply and ask questions, and then the authors have the right to respond to them. So it needs to be published by a journal that essentially has a group of reviewing panelists that say, yes, this is good quality work, we're going to publish it in our journal. Now each journal also has an impact factor, so you therefore know which are the good journals, which are the poor journals. And it's the only real way to assess it. If it's in a good journal with good people looking at it and critiquing it, then you know it's a reasonably good paper and good evidence. If it's published in the Woman's Weekly,
Martin.
yeah, or New Zealand Herald,
Yeah.
same thing.
Martin.
Yeah.
I've got a question, but I've got an observation. I was talking with a friend on Saturday night who's recovering from bowel cancer.
Yep.
And it was only when he was diagnosed and then started talking amongst his family that he found that there was a huge history, not only in the male members of his family, but also the female members of his family. And a number of them had died before they reached 60.
Mm.
And it struck me that this is something families need to be talking about and sharing that information.
Mm.
You know, be it all, it never happened 20 and 30 years ago, but we're in a time now where it should, and I would just encourage all of us to
Be open.
go digging.
Yeah.
Yeah.
Brian?
Just a comment, President Brian. In the Recording Club, when they did that bowel cancer scan, I think it was about 7 did it, and 2 came out with positive. Yeah, his lives were saved.
Yeah. Well, with bowel cancer, there's a very clear progression from a polyp, that we know exactly what happens from a polyp to a cancer. So you can find a clear precancerous lesion that you can treat and remove.
Ross?
There's been some talk about the side effects of statin drugs, and this interests me quite a lot. Would you like to make comment on that?
Statins are toxic. They're terrible. The problem is that the cell, every little cell in your body, has a membrane around it to keep the cell happy, the salt levels right and all that sort of thing. And in that membrane is cholesterol. So you need cholesterol to function. And there are, of course, the commonest thing are muscle aches and pains and myositis. My dad should be on them, but he can't play golf, so he comes off them. Doesn't take them. My mother should also be on them. She has a terrible coronary artery calcification. My history sounds terrible, doesn't it? Terrible coronary artery calcification score, and again, she has the same thing, the myositis. So there are a lot of side effects from them, but they work. So if you are on them and you've got side effects, it's very important that you see your doctor, because there are some blood tests that need to be done to check your liver and your muscles.
John?
Which drugs are the statins?
So they're lipid-lowering drugs like simvastatin, Lipex, atorvastatin, fluvastatin. There's a whole lot of. Most of them have statin at the end of them, and that's how they're sort of recognised.
Zetamide.
And yep,
John?
that's right.
What is the recommended interval between a screening colonoscopy? If one decided to go down that
Yeah. Okay. Well, it depends then on your family history and what they found at the last one. So if you found some polyps that were removed, you are more like they'll call you back probably within a few years. If it's been, because I'm not involved in this, but if it's clear, you'll have a longer interval.
I can do a
Maybe 4 or 5
Peter Corner. I can do a Peter Corner and report on that question. My GP asked me when I was age 59 for my family history, and my father died when he was 59. So he said, right, you're off for a colonoscopy. And I had a colonoscopy then, and sure enough, had polyps, which they tidied up. The next one was 18 months, and it was a small regrowth, but only small, and they said only 3 years for the next one, which I've had, and I'm due for my next one right now. Yeah. And so I believe that's why I'm here. Yeah. So it's the family history and everything about it.
Just one question, David. Selenium, and there's a lot of, again, following on from Malcolm's question, you know, where is the state of the research with selenium in it? Is it perhaps a protector against prostate cancer?
So there is probably no right or wrong answer there. There are a couple of different studies that have shown different things. It's probably not that important, to be honest. So it's not perhaps something we should be we need to be too worried about. It's easy to supplement with some selenium if you want to, but it's probably not a big factor.
Back to the PSA test, I understood there was a double negative problem with PSA tests, which was then leading to other examinations. Were you talking about that before? Or
So there's lots of problems. So the average PSA is about 0.8, and there's a reference range that you look at. 0.8 for a 50-year-old man, there's a reference range. As you age, the PSA goes up. Some bad prostate cancers secrete a type of because bad prostate cancer is all wild and looks funny and funny cells, so it secretes PSA. It doesn't look like the normal PSA, so you send that blood sample off to the lab and it won't recognise the PSA. So sometimes you can have a bad prostate cancer with a low PSA, is kind of what you're referring to. So even a normal test sometimes is slightly misleading unless you've had an examination.
Last question.
So the examination, that's where people go wrong. The examination always picks up those cancers. A proper examination never misses those.
I heard somewhere where if your overall cholesterol reading was very, very low, it brought about depression. Is that correct or not?
Yeah, so that's called the J curve, and that was a big concern initially, where your chance of dying goes down as your cholesterol goes down, but then there was a little flick at the end, and the concern initially was with suicide and low cholesterol levels.
How low would it need to be?
Well, it needs to be under 1.
Oh,
For both.
Don't jump
Oh, right, deal.
Dr. John Silcock.
It fascinates me that, here we are talking about men's health, and yet all we've discussed is diseases. The professors of paediatrics don't call themselves professors of paediatric disease. They're professors of child health, and yet all they do is study diseases. They do very little in the immunisation and prevention and the maintenance of health, I must say. And as far as the maintenance of health goes, I would put exercise really right at the top of that list. Regular strenuous exercise, I think, does more for late middle-aged men's health, their mental attitude and their outlook, than pills and a finger up the bum.